Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. Neelam Path Lecture dedicates its next set of lectures in solidarity with our doctor fraternity and in loving memory of our martyred sister Abhaya. Surely your sacrifice shall not go in vain. As you are aware, all our lectures are available on YouTube. We also have a Telegram group which you can access for accessing all lecture related information. We have a Google Drive where the PDF of all lectures are available. These are the disclaimers. And we are with phase 3 with his recorded pathology lectures. And today's topic is cervical cytology, glandular lesions and their qualms. And to talk on that, we have Dr. Meherbano M. Kamal. She is an MD, PhD, MIAC, ex-professor and HOD of the Department of Pathology, GMC Nagpur, India. She is a trained cytopathologist from AIIMS, New Delhi, with a teaching experience of more than 36 years and a postgraduate guide for 29 years. She is a national editor for Acta Cytologica from 2020 to 2022. She has authored a book called Uterine Cervix Cancer and the Bethesda System. And there's a series of lectures which she shall be taking, and the next lecture would be Cervical Cytology, Challenges of an Inflammatory Smear. With that, let me request Dr. Meherbano M. Kamal to start her talk on cervical cytology, the glandular lesions and their qualms. Over to you, ma'am. Thank you so much.
Hello everyone. At the very outset, I would like to thank Dr. Nadeem and the Neelam Path Labs for giving me this opportunity to interact with you all on the topic of glandular lesions of the cervix and their qualms. Friends, any talk in cytology or any event in cytology is incomplete without paying tributes to Dr. George Nicholas Papanicolaou and his wife Andromache Mavrogyny. Both of them received many awards and accolades for their untiring scientific efforts in discovering and establishing the utility of cervical cytology. But this highest honor came in when the scientific community at large decided to name cervical cytology as the Pap smear. Papanicolaou's original work and its numerous refinements by iconic George Weed, Leopold Koss, Frost, Patton, Regan, Zurhausen, and others gave birth to cytopathology as a subspecialty of pathology. As is well known, cervical cytology is a screening test primarily to detect the squamous intraepithelial lesions and squamous cell carcinomas. But now our second eye has opened for the second epithelium of the cervix, that is the glandular epithelium. There is a gradual increase in the detection rate of glandular lesions over the last 2 decades, and an actual increase in the incidence of glandular intraepithelial neoplasia and endocervical adenocarcinoma has been reported worldwide to have been increased from 0.1% to 2.5%. The possible reasons could be firstly, refinement of the cytomorphologic criteria along with our heightened awareness and training, thereby leading to an increased ability to identify abnormal glandular cells. And secondly, better collection devices have played an important role. These brushes and brooms sample not only the high endocervical canal epithelium but also fetch cells from the glandular crypt openings. But despite these facts, there are diagnostic challenges and drawbacks related to either sampling and interpretation or both. Now, what are the sources of glandular cells in a pap smear? Primarily, yes, the endocervical glandular cells. Then you have the cells trickling down from the endometrial cavity, but you do have extrauterine sources like the fallopian tubes and the ovaries, and sometimes the source cannot be very clearly defined, and then you can write it down as not otherwise specified. Now coming to the causative factors, HPV-18 is commonly implicated in the as a causative factor for endocervical adenocarcinomas as compared to squamous cell carcinomas where 16-18 are more common. When we compare squamous and glandular lesions, reactive cellular changes associated with inflammation are noted in both and are easy to diagnose. However, a low-grade endocervical glandular entity analogous to low-grade squamous intraepithelial lesion has not been well established either histologically or cytologically. Like the ASK-US, ASK-H, we do have the category of atypical glandular cells. However, there is a significantly lower rate of detection of high-risk HPV in the AGC category lesions as opposed to 40 to 50% in ASK-US and ASK-H. Now, endocervical adenocarcinoma in C2 is considered to be the glandular counterpart of high-grade squamous intraepithelial lesion, that is HSIL, and the precursor to invasive endocervical adenocarcinoma. And for the squamous cell carcinoma, we have a parallel entity of adenocarcinoma. While reporting glandular cells, there are two challenges. First, difficulty lies in separating the grains from the husk, that is separating the actual AGCs from the reactive glandular cells and on one hand, and separating the AGCs from cells of adenocarcinoma in situ on the other hand. The second challenge is categorizing the origin of the abnormal glandular cells as to which part of the female genital tract they belong to. If you are unable to do this confidently, whether they are endocervical or endometrial, you can just use the generic term glandular cells or not otherwise specified. It is just enough that you are correctly identifying the endometrial cells in a pap smear, whether normal or atypical. This is what the Bethesda system says. Now it says that you need not go any further to specify that this atypia is favoring a neoplastic process because it is difficult to do so for the endometrial cells. But for the endocervical cells, you can definitely see the cytological findings and decide whether it is favoring a neoplastic, and if you are not sure, still you can use the term NOS. But for the endometrial cells, as I said, it is difficult to do so, and you may not try to venture upon it. Now, overall, the incidence of atypical glandular cells has been reported somewhere between 0.08 or 0.1% to 2.5%. To emphasize once again additional highlights of this atypical category for glandular cells is that the term AGUS, that is atypical glandular cells of undetermined significance, is not used to avoid confusion with the ASK-US category of the squamous cells. Secondly, do not use the term favor reactive, just use NOS whenever you are in doubt whether these are reactive cells or they belong to a neoplastic process, because in a significant percentage of cases atypical NOS represents reactive mimics. Now, atypical glandular cells, as I told you, should be further categorized to the favored site of origin, endocervical or endometrial, whenever possible, because the clinical workup and management for patients with glandular abnormalities vary significantly depending upon the cell type. And if you're not very sure, then just use the generic term AGC. That terminology can be used. Now, whenever it is atypical favored neoplastic, you can go further till endocervical cells, but this is not possible for the endometrial cells. We will just have a look at the normal endocervical glandular cells as they appear in a cervical cytology smear or a pap smear. This is the classical honeycomb appearance that you see in liquid-based preparation. Because of the shearing force of vortexing, the cells are generally formed singly or in this rosetoid pattern or cartwheel type of pattern. But in conventional smears, you can see them sticking to each other in the form of stratified or pseudo-stratified columnar epithelium as they are in their histological type. Here again you can see the pseudostratified columnar endocervical glandular cells. And here you can see the transition from the columnar cells to the honeycomb pattern, and the cytoplasm is abundant and lies at the periphery. And this is the classical picket fence appearance which Cos used, where you have a tail of cytoplasm at the tip, and maximum cytoplasm is present at the bottom. In severely hyperplastic epithelium, you can see this abundant cellularity comprising of the glandular cells along with the inflammatory cells, and there is cell crowding and overlapping, and like this type of pseudogiant cell formation. And you can see micronucleoli in the nuclei, and pseudopolyps can be seen. And generally the origin of these cells is from these large erosions with hyperplastic epithelium. These pseudopolyps, they do not have a fibrovascular core, and therefore they are not the true polyps. This is a monolayered sheet of glandular cells showing a nuclear enlargement, slightly increased NC ratio, multiple nuclei, and fairly abundant cytoplasm. And these reactive nuclei of glandular cells are generally because of an inflammatory process, and you can see they are intricately mixed with inflammatory cells. Here you can see the transition from normal glandular cells in a honeycomb pattern to slightly reactive nuclei. Here again this honeycomb pattern is maintained, but there is a little disturbance in the pattern, and the nuclei are slightly enlarged in size. Now here you can see the pseudostratified columnar epithelium with slightly hyperchromatic columnar looking nuclei, and as you can see here there is fairly abundant cytoplasm. So these are very easily recognized as reactive endocervical cells or reactive cellular changes associated with inflammation. In liquid-based preparations, the honeycomb pattern is generally lost, and secondly, the cell groups are more rounded and three-dimensional with piled up layers of cells, making individual cells in the center difficult to visualize. On the other hand, single cells are plenty where you can assess the nuclear chromatin. Vigorous sampling with brooms and brushes may bring out such intact microbiopsies of glandular cells from the lower uterine segment, and this generally happens when the endocervical canal is short and LUS is approachable. This is called the brush artifact. When you get such thick microbiopsies and you cannot assess the cells in the center, you have to be very careful before labeling these cells as atypical glandular cells, because you are really not able to see the nuclear chromatin and the other architectural features which are required. They are just thick clusters of endometrial cells. Now, how do you report such smear findings? Because this is, you are very sure that these are reactive cellular changes associated with endocervicitis or inflammation. This smear will be reported like any other inflammatory smear, and in the general categorization section you are going to write reactive and reparative changes of inflammation, NILM, and in the notes section you can write all the details of the endometrial cells that you were seeing in thick sheets and clusters. Now just compare the endocervical glandular sheets in these two pictures, and now you can see that the honeycomb pattern is fairly well maintained in this sheet of cells as compared to this one where it is slightly disturbed, along with the nuclear abnormalities that are seen in both these sheets. There is nuclear enlargement, hyperchromasia, and high NC ratio. The nuclear enlargement up to 3 to 5 times the area of a normal endocervical glandular cell is taken as the benchmark for nuclear enlargement. You can see the crowding of the cells in a gland, in the tubular pattern of the glands. And when you start seeing such sheets of cells, flat sheet of cells, with high NC ratio, they somewhat start resembling high-grade squamous intraepithelial lesion. And sometimes, although you report it as atypical endocervical glandular cells, NOS, follow-up biopsies turn out to be H cell within the glandular crypts. These sheets of endocervical glandular cells upfront appear atypical because of the increase in nuclear size, variation in shape and size of the nuclei, hyperchromasia, multiple and prominent nucleoli. But if you observe closely, the nuclear contours are very smooth and round, and the distribution of the chromatin is very even. Now, this patient of mine on follow-up colposcopy showed an atypical transformation zone and a healing erosion with variable intensity of acito-white lesions all over the transformation zone. Follow-up cytology and biopsy showed NILM. All these are endocervical glandular cells. They are all abnormal and atypical, and you can see them and they are present either as crowded clusters with overlapping nuclei or such small strips of columnar looking cells or such flat sheets. The common thing is that they are all abnormal and atypical, and there is significant nuclear enlargement, almost up to 5 times the size of a normal endocervical nucleus. The chromatin is fine to coarse and it is heterogeneous. There is hyperchromasia, there is increase in the NC ratio, as you can see in all of these cells. But there is the cytoplasm is still moderate to abundant and it appears lacy. Now, all these findings are very subjective, and if you are not very sure, you can put it as atypical endocervical glandular cells not otherwise specified. By definition, atypical endocervical cells not otherwise specified are cells that display nuclear atypia, which exceeds obvious reactive and reparative changes but lack unequivocal features of endocervical adenocarcinoma in situ or invasive adenocarcinoma. Colposcopically, such lesions generally present as healing erosions, and here you can see an acito-white metaplastic island in the transformation zone. In addition, you can see these glandular crypt openings surrounded by a dense rim of acito-white epithelium, and this could probably be the source of these atypical cells. And now in your reporting format, you are going to very clearly write in the general categorization that there is epithelial cell abnormality and it is glandular. And in the interpretation section, you can further qualify these cells as atypical endocervical cells, NOS. And in the notes section, you can write all the details and of the nuclear and cytoplasmic findings and as to how these cells are falling short of the neoplastic process or neoplastic findings. Now here you are seeing highly atypical atypical cells in sheets and clusters with higher degree of nuclear crowding and overlap. Such clusters often turn out to be HSIL, and almost 50% of the times on complete workup of the patient, they turn out to be high-grade squamous intraepithelial lesion that have extended into the glands and its crypts. So, but here you can see some rosette-like arrangement of these cells in each of them. Here again you can see a rosetoid arrangement. Here also you can see, which gives you a clue that these cells are of glandular origin, and the nuclear features are definitely favoring a neoplastic process. Now here you can see pseudostratified strip of endocervical glandular cells and a half gland-like or acinar arrangement with crowding and overlapping of dense hyperchromatic nuclei. Here you can see the nuclear details better. Now you can see that the nuclei are not only enlarged but they are pretty much elongated and with slight hyperchromasia and coarse, fine to coarse chromatin which is evenly distributed. But the cytoplasm is still discernible and has very nice cell boundaries. Here you can see some terminal bars are seen. You have to remember one condition, that is the tubal metaplasia, which is a diagnostic pitfall and can be reported as AGC favor neoplastic process. But in case of tubal metaplasia, you get not only the terminal bars but also the cilia are seen. Although sometimes it's difficult to identify both, and then you fall in the trap of reporting the benign cells as favoring a neoplastic process. In liquid-based preparations, AGCs may come as HCGs, that is hyperchromatic crowded groups, or as three-dimensional, very densely packed layers of cells obscuring central nuclear details. In such case, then you have to bank on the morphology of the nuclei jutting out from the periphery. Now this also could be just a brush artifact, meaning that the bristles of the brush, they bring out such large number of glandular cells and they are not well spread, and they just form cell clusters in liquid based preparation. And in such cases you must have more samples or areas where you can see architectural features and nuclear features before labeling them as AGCs favoring a neoplastic process. Now, some neoplastic processes that may show atypical cellular changes include, and these are benign conditions, and they lead to interpretative difficulties and include lower uterine segment sampling, tubal metaplasia, exuberant repair, endocervical polyps, microglandular hyperplasia, area change, etc. Now, how are you going to report such findings? In the general categorization, you have to be very clear that there is or there is not an epithelial cell abnormality and whether or not it is glandular. If so, you have to mention it. Then in the interpretation section, you can go a little further and report them as they are atypical glandular cells and you are sure that they are favoring a neoplastic process. And then in the notes section, you can write all the difficulties that you are having or in interpreting the morphology of the cell clusters and the nuclei. And you can even suggest colposcopy if the woman is more than 35 years of age and has abnormal bleeding, or if there is any clinical indication, you can suggest colposcopy with endocervical sampling and or endometrial sampling. As you proceed towards the lesions like the endocervical adenocarcinoma in situ, we start seeing typically oval nuclei that are crowded with nuclear overlapping, and they start showing much more hyperchromasia with evenly distributed but coarsely granular chromatin. The cytoplasm becomes lesser because of the high NC ratio, and the pseudostratification is also obscured, like you are seeing here. These are the strips, but there is hardly any cytoplasm to show the pseudostratification. But what becomes prominent is the feathering of the nuclei. Now these are the nuclei that are jutting out from the periphery of the cell clusters. Here again you can see the nuclei jutting out from the periphery. These are all cell clusters seen in a conventional smear. Now, these are some more microphotographs from a case of adenocarcinoma in situ. You can see the phenomena of nuclear feathering very nicely in this. Dark hyperchromatic oval nuclei are jutting out from the periphery, and then here you can see some central rosetting which is very vague. Again, here you can see some central rosetting with periphery, could be of the pseudo-stratified strips, but the architectural features that were very prominent in the favored neoplastic category, now we start losing them, and there is a hyperchromatic oval round nuclei which are showing a lot of crowding, and this phenomena of bird tail appearance starts coming in, where you have a collection of the hyperchromatic nuclei at one pole and fanning of the cytoplasm at the other end. And this was made of one of my friends, and when we did the histology of this patient, that is endocervical curettage, the histopathology showed a lesion of adenocarcinoma in situ. In liquid-based preparations, architectural features of peripheral feathering, rosettes, and cell strips have a more subtle presentation. Hyperchromatic crowded groups are more common, and they are smaller, denser, and more three-dimensional, and they have a smoother and sharper margins. The bird tail-like appearance or small strips of cells or pseudostratified strips are often most commonly represented in liquid-based preparation. You can see one of them over here in the form of a short bird tail-like appearance. The nuclear chromatin, however, is coarse and finely granular. In liquid-based preparations, when you do not get HCGs, the predominant cell type could be just single columnar looking cells. And this is also because of the vortexing of the vial, which leads to dispersion of the cells. So here you have to carefully look for the nuclear features. You can see the nuclei as enlarged, dark, hyperchromatic, oval to elongated, and the nucleus is present at one pole of the elongated cytoplasm, and this is here you can see the single cells with nucleus distending the cytoplasm at one end, and this is known as the snake and egg appearance. Here the snake has eaten up the egg, and this portion is swollen, and you have a short tail of on this side and another long tail on this side. So this snake and egg appearance is generally seen in single malignant looking cells in liquid based preparations. When a high-grade squamous intraepithelial lesion extends into the glands, resultant cell clusters, when they are seen in the smear, they may be misinterpreted as being of glandular origin. Clues that the lesion is actually of squamous origin includes 2 or 3 features which you need to keep in mind. Now, like you are seeing in this biopsy, there is swirling and whirling of the cells within the cell cluster. So similarly, you will have such representative cell clusters where you can see central swirling and whirling of the cells. Then you will have a flat edges to these cell clusters. Like here, you will have the flat edges to these cell clusters. Here again you can see this flat edge, and this come in the smears as blocks of epithelial cells with one edge which is flat. The third clue is that there is flattening of the nuclei at the edges of these clusters. So here you can see the nuclei become more flat and more spindly on the edges of these cell blocks. Sometimes you can get occasionally you start getting such single keratinized cells in the smear where, when you carefully look at the smears. So these are the clues that these cell clusters or HCGs belong to a high-grade lesion which is extending into the glandular crypts. And most important is that there are these cell clusters, they lack the glandular architectural features which we saw, like pseudostratified columnar strips, then acinar arrangement or feathering. These features are lacking in the smear. Now, as you proceed towards a lesion that is invasive adenocarcinoma, you start getting such very nice uh, uh, glandular structure or acinar structures with elongated nuclei and hyper that are hyperchromatic with coarse chromatin, and also the cells they may look very round and there can be a monotony of the cells, and then you have to look for tumor diathesis in the background, which is usually in the form of watery diathesis, and in the LBC prepletion it is a clinging type of diathesis. The second common glandular component in cervical cytology smears are the endometrial cells. Now, normal endometrial cells decrease in number by the 6th day of the menstrual cycle, and they almost disappear by the 10 to 12 day. Exfoliation other than this time must be considered as abnormal and is known as out of phase shedding. Now, during the shedding, you can see these endometrial cell clusters like this, and this is a classical drop hat appearance, wherein in the center you have the compact stromal cells surrounded by the rim of a few layers of the endometrial glandular cells. Now, these are known as exodus, and this out of phase shedding has to be reported in women more than 45 years of age. The only difference in the Bethesda system 2001 and 2014 is the age for reporting endometrial cells, regardless, that is the age for reporting endometrial cells, and which has been increased to 45 from 40 years regardless of the menstrual status, and clinical correlation is recommended. Benign appearing endometrial cells in women under 45 years of age need not be reported even if they are seen during the luteal phase or out of cycle, because they have little if any predictive value for endometrial neoplasia. Now, endometrial cells are morphologically they are much smaller. Also, uh, they show much less variability in nuclear size. Cells often are arranged in tight ball-like clusters and rarely as isolated cells. So you can see these tightly arranged knobby clusters of endometrial cells. Then the nuclei are small, similar in area to a normal intermediate squamous cell nucleus. The smear background is dirty because of the crumpling endometrium, and plenty histiocytes are seen, and also such concretions can be seen. So here you have these plenty of histiocytes, and dirty background usually comprises of cytoplasmic debris, bacteria, and lysed RBCs of the crumpling endometrium. The cells are largely degenerating, and a lot of apoptotic bodies can be seen. And now these are the various clinical conditions in which you can see shedding of the endometrial cells apart from the normal menstrual cycle. In LBC smears, the background is much cleaner, and endometrial cells are seen either singly or as small three-dimensional cluster. So here you can see these similar knobby, dense cellular clusters, and the cells are very small in a clean background. You can also get this a drop hat type of appearance, but here you can see it as a disturbed drop hat because of the vortexing of the vial, or you may get the cells in the form of such dark three-dimensional cell clusters. The nuclei of these cells are very small, and when they shed spontaneously, and the cells appear crowded, and the nuclei may sometimes appear degenerated, hyperchromatic, and you can also call them as hyperchromatic crowded groups. Now, how will you report such a slide? If the patient is less than 45 years of age, and you have the her LMP with you, then you can write in the notes section that the endometrial cells correlate with the menstrual history provided. But in a woman who is more than 45 years of age, irrespective of the um, uh, menstrual history made available to you, you can still report, you can add in the notes that endometrial evaluation is recommended in this woman. Direct sampling of the lower uterine segment can happen with the usage of long brushes and brooms or following cervical conization. Now, abraded lower uterine segment fragment at times shows a biphasic glandular stromal complexes with capillaries. This is a microphotograph taken from the book of the Bethesda system, and here you can see the glandular cells in a dense cluster surrounded by the stromal cells and the capillaries traversing through these spindle stromal cells. Now, presence of abraded LUS or endometrium does not have the same implications as exfoliated endometrial cells. Important is that only spontaneously exfoliated, not directly sampled endometrial cells should be reported. Cone biopsy artifact can be a diagnostic pitfalls, but you have to closely look at the single cells. There you get a lot of plenty single cells, and have to closely observe the quality of these single cells. And when you get the clusters in this cone biopsy artifact, they are less crowded, there is less overlapping of the cells, and they do have the indications of a benign sheet or a cluster. Another diagnostic pitfall are the cells shedding from the endometrium in a woman who's wearing the intrauterine device. Because of the constant irritation of the device, the cells generally trickle down as single cells, and because of their long-standing secretory nature of the endometrium, you can have such vacuoles within the cytoplasm with nucleus pushed towards the periphery. Again, you can see this large vacuole and atypical nucleus push to the periphery. You can have even multi-vacuolation of the cytoplasm. And these atypical cells with a huge vacuole can be mistaken for malignant cells coming either from the endometrium or from the ovary. But if you observe closely, there is a dirty background, there is a lot of polymorphs in the background, and they sometimes also come along with in patients who have endometritis. So carefully report these and take the help of history, and if you are not, the history is not provided, you may ask for the history whether she is wearing a IUD, and the duration of the IUD is very important. A variety of conditions can exfoliate atypical endometrial cells, and you have to decide whether they favor a neoplastic process or not. Cells that favor a neoplastic process, they appear in small tight groups like these, as you can see them here. Such tight clusters are seen. Cytoplasm of these cells is very scant, and sometimes it can appear vacuolated. You can see these vacuolations. Cell borders are ill-defined, and the nuclei, they appear very dark, and the nucleoli are inconspicuous. Now, sometimes you get a finely granular or watery tumor diathesis, which is variably present and is commonly seen in conventionally prepared smears. In liquid-based preparations, the endometrial cell groups appear above the plane of the squamous epithelial cells. They are tight three-dimensional clusters, and you can have plenty single cells. And nucleoli and chromatin details are better seen, and they are more apparent, whereas in the conventional pap smears, the intracytoplasmic vacuoles are more common and they are more easily available. Karyorrhexis is easily seen, and you can observe this watery diathesis around the cell clusters, which is more apparent in the conventional pap smears, and whereas it is not that easily seen in the LBC preparations. Now, this is a patient who was 63-year-old, and her conventional pap smear showed such small cell balls and of glandular cells, and the cells were hyperchromatic and the cell clusters were very compact, and at places they showed this flat appearing sheets, and at places there were such large obviously malignant looking cell balls. On complete evaluation, it was found that the patient had endometrial adenocarcinoma, and here you can see all the details of the nuclei and the cytoplasm favored endometrial adenocarcinoma. This is another case of endometrial adenocarcinoma being represented in the conventional pap smear. Here you can see a tight cluster of abnormal nuclei, and here this is a histiocyte with engulfed debris, and as the grade of the endometrial carcinoma increases, you can get more abnormalities. Larger nuclei, multiple macronucleoli are also seen, along with a high NC ratio and other malignant nuclear features. So to summarize, the challenge while reporting glandular cells in a cervical cytology smear, whether it is LBC or conventional pap smear, is that you need to differentiate the endocervical cells from the endometrial cells. Secondly, you need to be very confident whether these endocervical cells that you are seeing are not otherwise specified, or they favor a neoplastic process. And similarly for the endometrial cells, whether they are NOS or they are favoring a neoplastic process. So when it comes to the category of favoring neoplastic, and when you are sure that you are dealing with the endocervical glandular cells, look for these architectural abnormalities like the pseudostratified strips of columnar cells, single cells, rosette, cell balls, bird tail-like appearance, feathering, and along with the cell size. The cell size will be larger with the endocervical cells, and the cells will be smaller, much smaller in size when they are endometrial glandular cells. And of course the nuclear features are very important. The nuclear NC ratio will be increased, there will be hyperchromasia, the nuclei will be very elongated, oval in case of endocervical cells, but with the endometrial cells they will be very small, round, and mostly degenerated in nature. Now, according to McDemey, when you are dealing with the glandular cells, from the half-empty perspective, the sensitivity of an interpretation of atypical glandular cells uh, for adenocarcinoma in situ or invasive carcinoma is only about 50%, and the specificity is 20%, and the predictive value is miserable, almost 5 to 10%, at the most 0 to 34% in some series that have been reported. Most of the significant, second important thing is that most of the significant lesions that are detected as glandular, they turn out to be squamous in nature. That is, in almost around 75% of the cases they turn out to be squamous and not glandular, and around 60% do not have significant lesions at all on follow-up. From the half full perspective, however, atypical glandular glandular cells is a high risk result that predicts adenocarcinoma in 5 to 10% cases, and clinically significant abnormalities are found in around 80% of the cases. So all in all, overall, there is a trade-off between sensitivity and specificity while diagnosing glandular lesion in a cervical cytology smear. Thank you for your patient listening, and you can refer this book of mine for further interpretation.